Audio Jungle.
Hello everyone. How are you? कैसे हैं आप लोग? I hope you are doing good, staying safe, and taking good care of yourself and your loved ones. Well, it was in the month of I think end of August or September when I had a word with Dr. Nupur, and she told me about the conference that they were planning to have. And my first reaction was, to be honest, I was not as excited as I'm today, but I was more curious how it's going to happen, how like 40 speakers they are planning, and then they're planning cultural events, they're planning award night, they're planning DJ night. So I was more curious, but a lot curious, in fact. But 2 months to 2.5 months down the line, when I see how beautifully it has shaped up, I get the feeling of, I'm very proud to be associated with this conference, which is, as all of us know, DRDCA 2020. It's a team effort. Dr. Roxon, Dr. Nupur, Dr. Manu are some of the people I know. So it's overwhelming to see basically how everything has shaped up. So I am Dr. Pallavi Mahajan. I am an endodontist, a writer, and a spoken word artist. So basically, I write in Hindustani language and I perform the same on stage. But today and for the rest of the month of November, I'm your host for all the scientific sessions that we have scheduled for you guys in the month of November. Scientific sessions are scheduled for every Thursday, Saturday, and Sunday. Thursday being a weekday, we have just one evening session. For weekends, we have two sessions, one in the morning and one in the evening. We have almost 40 speakers with us from all over the world who are speaking about the fields, their respective field of expertise, and sharing their not just the dental part or just the session, just the uh, scientific part, but also their journey in between. So it's the scientific session started on 1st November with the conference. Also, if you have not downloaded the app, download the app right away. The lectures are available, like you can see the sessions on YouTube and Facebook, but with app you get a whole lot of benefits. You will get a participation certificate, you will get 40 CD points, then you can take part in cultural contests, dancing, singing, poetry, and whatnot. Also, you have a chance to win a Novolace laser machine. Novolace laser machine. One lucky person will get the chance to win that. And for that, the prerequisite is you have to download the app and register yourself. And other rules I will share with you post the session. Session started on 1st of November. On the first, we had two speakers with us, Dr. Sigal from Australia and Dr. Raj from India. The sessions are still available on YouTube and DRDCA FB page. You can anytime go and see the sessions. Today we have on board with us Dr. Davis Thomas, who's joining us from United States of America, USA, and Dr. Sonal Yerpude, who's joining us from Mumbai. Dr. Davis Thomas is an orofacial pain dentist who's practicing all aspects of dentistry with special focus in the treatment of obstructive sleep apnea. He's an advanced level consultant to insurance companies and law firms. Uh, he also conducts independent medical and dental examinations and provide expert testimony for them. Dr. Thomas did his bachelor's from Manipal, DDS from New York University, USA, MSD, Masters in TMD and Orofacial Pain from New Jersey, USA, MSc Medicine, Masters in Sleep Medicine from Sydney, Australia. He's a diplomat, American Board of Orofacial Pain, Fellow, American Academy of Orofacial Pain, and is currently pursuing MSc in Clinical Pain Management from UK. So basically, Dr. Davis Thomas is somebody who actually, inspires you if you talk to him. And he believes that his main identity is is of, mentor, as a mentor. Um, his student Sonal, Dr. Sonal Yerpude will join him, and Dr. Sonal Yerpude did her BDS from Mumbai DY Patil University. She has a certification in aesthetic dentistry from NYU College of Dentistry in New York, certification in advanced implant prosthesis from Italy. She's a fellow OFP, TMD, and dental sleep medicine um, from Smile USA Academy and Roseman University, USA. So, Dr. Davis Thomas and Dr. Sonal Yerupade is going to speak about a new specialty, um, orofacial pain. It is the newest 12th specialty which is approved by the Commission on Dental Accreditation, CODA. Uh, American Academy of Orofacial Pain defines OFP as a specialty of dentistry that encompasses the diagnosis, management, and treatment of pain disorders of the jaw, mouth, face, and associated regions. So let's hear from them. I welcome, and it's a great honor for us to have Dr. Davis on board with us and I welcome Dr. Davis Thomas. Dr. Thomas, screen is yours. Mic is muted. Dr. Thomas, kindly unmute yourself.
Yes. I do it all the time. Thank you, Pallavi, for that beautiful introduction. And thank you to and all the organizers that have actually contacted me, and I spoke to them that helped us make this thing happen. My students are probably joining from quite a few countries, so I don't want to say good morning, but whatever the hour is, a good day or good evening to all of them. And I thank you all for joining us today in this just a little introduction on the 12th new specialty of dentistry, that is orofacial pain. Pallavi was talking about the journey that some of these mentors went through. I've been known to be a tough mentor in that way. I'm stoic in my own ways, but I think the vast majority of my students would agree that I have treated them with love, respect, and the care that a mentor should be offering his or her mentee. And yes, Sonal happens to be my mentee. She's in the 150 hours program with Smile USA and Roseman University. Um, and it's one of the best programs, not because of my program, I'm the course director, obviously, but it is a structured, really structured program in orofacial pain. So we look at a few of these principles um, of orofacial pain and some associated subspecialties that might be coming up soon, maybe. And we'll look at that context as well a little bit, time permitting. Whatever happens, if I am going slightly over time, I'll stop and I'll let my student, who is a wonderful physician, a wonderful lecturer, and such hardworking person, Sonal, to take her chance of presenting something to you too. These are the times when I have to allow my mentors to present. Over the last 15 years, I think I've presented a lot, but This is their chance to share the stage with me, and I'm very proud of her. So without further ado, I hope the screen can be seen. I'm going to try. If you want to give me an input on Pallavi, if you can let me know if the screen can be seen. Are you there?
Yes, yes, it's visible, sir.
You can see the screen and hear me well, right? I can hear you. Pallavi, can you hear me well?
Yes, sir, I can hear you well, and the screen is also very clear.
All right, thank you, dear. So we're going to talk a little bit about orofacial pain, which is the 12th specialty. I have nothing to disclose, no conflict of interest, nothing to sell either. Um, there are people who use their platforms, I think, to sell it. I don't have anything. I don't have a product to sell to anyone that is listening today. If I can share some knowledge, that is the best that I can get. I always have a slide on this slide, which is one of my favorite ones ever in my entire life. That is saying Tamasoma Jyotirgamaya, which is that the light of knowledge will take off the darkness of ignorance. And I abide by this my entire career. So there is then orofacial pain, the 12th specialty, which was just announced, as you can see on the screen, March 31st, 2020, the American Academy of Orofacial Pain's request. When I say request, it has been a request, it has been a fight for the organization for a long time, of around 25 years plus. But in the end, um, actual knowledge will persist, and it did. And hence, we have the ADA 12th recognized specialty of orofacial pain. I implore you, and it's my firm belief, opinion, that if anyone listening to us today, even in the slightest interest in this field, please look up this book, which is the 6th edition by the American Academy of Orofacial Pain. If you would like an evidence, science, literature, and truth-based education, you please look into this thing. It's by Quintessence Publications. The director of that Quintessence, the main editor, chief editor, is my mentor as well. So please look at this, and it will tell you evidence-based and science and literature-based stuff. I implore you, I really recommend this to any beginners that can have a look at this vast ocean field of orofacial pain. And our 45th scientific meeting will be in Arizona. It's coming up in Scottsdale. And yes, yours sincerely, Dr. T, will be there as the 10th plenary speaker. It is an honor, and that's why I put this up, and I'm proud of it. I feel extremely blessed. I'm too young, even at 50, to share the stage with giants in pain, not just orofacial pain, in pain, the ones that are on this brochure. Please look at AAOP, American Academy of Orofacial Pain. This is Dr. Gary Hare's commentary in Journal of American Dental Association. Happily and with content, explaining why orofacial pain was necessary and why are we so elated. That's the word I will use, and content. The primary purpose of this being a specialty now, the 12th specialty, is for the patient's perspective. That is who we are protecting. There is a lot of science, and then there's a lot more of pseudoscience happening in the field of orofacial pain. And it has happened for the last 50 years, nothing new. But now, at least in my humble opinion and my research and belief, I think, and hundreds of others would corroborate the same, there is a new sheriff in town for science, evidence, literature, truth-based search for a lot of these diagnoses and management plans. So this is from Dr. Hare, who is my clinical mentor and one of the best I've ever had. Well, you can see a familiar face there. So as students of science, I don't care if you've been practicing for 5 days or 50 years, I think it behooves upon us to keep learning, and this is the last and the continuing batch. They're the fifth batch of fellowship, and of course, Sonal is one of them. There are a bunch of students that I'm super proud of, and with my best friend and colleague, Dr. Shankar Iyer from Smile USA, we have brought this program to India. This is for the purpose of science only. It is not to compete with any other philosophies. They can have their fun. But if you talk science and literature, then this is for you. And of course, Sonal is an integral part of it. So, recognition of the specialty. Why should we have another specialty? Because of the overlap with a lot of other specialties as well: oral surgery, oral medicine, radiology. There's a lot of overlap. And I love and respect prosthodontics, ortho, and endodontics are very close to our heart. So we love and respect all those, and we convince them saying, but, but we need a lot more than just being interdisciplinary. And that is what led to the specialty, which has now become probably one of the most vibrantly talked about specialty inside dentistry. And I'm very content and happy that in a small way, I was part of it as well. I am proud that I brought this science to India. And all the world leaders in this field have, many of them have called me, texted me, congratulated me, only because India is one of the best places for brains, the best brains. And there are a few other countries that come into my mind. And so I was proud to bring it. And yes, it has flourished. And I hope and pray to God that this science will continue to flourish there. That's where I live. This is where it's going. My passion is orofacial pain. There's a reason for it. I have a little caveat here. Please make sure that 1.5 hours of this orofacial pain is in no way any match for any of the courses we give. It is not to prepare any of you listening there for starting to understand the subject in detail. That should be a structured program like any other specialty, whether it's oral medicine, oral surgery, prosthodontics, endo. You have a structured 2 to 3 year program. And this is a very similar structured 150 to 400 hour program. So please, I implore you not to do a diagnosis or treatment plan or based on the little droplet that you hear today. So what is the scope of orofacial pain? TMJ, temporomandibular joint disorders, musculoskeletal. They form a large group, but that's not the most exciting group. But I must say, there's a lot of pseudoscience that goes behind this. A lot of principles that we thought from the 50 years ago, or maybe 60 years ago, that was written up, have proven to be totally false and wrong. Some of those principles are gold. And I understand those principles are still to be used when we, as physicians of the stomatognathic system, we restructure the mouth, we restructure the tissues, especially for optimal aesthetics and function, speech included. Then those principles, mainly the principles of occlusion, come into play, but not in a living, otherwise normal human being complaining of a TMJ pain. That would be the wrong concept as of now, literature stands. So it's a large component, but not the most biggest component that you should think of. But we have principles of practice supported by abundant, robust literature that will support how to diagnose these cases and manage them. And absolutely no, it's not by connecting that head to some type of machine. There is an art of diagnosis, which I implore you and I recommend that type of science be looked into. Neuropathic pain, we have trigeminal neuralgia, neuropathies, and persistent post-traumatic trigeminal neuropathy. Please look up these terms. It's way beyond the scope of this an hour and a half to even begin to explain what these are. But I can tell you the principles that I thought were true 25 years back when I did my undergraduate, absolutely not true anymore based on literature, science, and evidence. Neurovascular, can a headache appear on the face? Yes. And no, connecting that head also to a scanner or something will not be the answer to this either. But they will come to you complaining of what else? Toothache, or what they think is jaw pain. Trigeminal autonomic cephalalgias. When I speak about this, people look at me and say, "What the heck did you say?" I'm not calling anyone a name. It is the truth that a lot of these cases, not a lot, I would say most majority of those cases are misdiagnosed by dentists who think they can diagnose these type of entities that I'm listing here based on the bite, based on some weird nerve and muscle function. It's not going to happen. Those patients will be hurt, their relatives will be hurt, both physically, emotionally, and financially. And that is why this is a specialty. Non-odontogenic toothaches, we see this every day. I teach at a couple of universities, a couple of days a week, and this breaks my heart when I see cases handled by dentists who, amongst our group, it's amongst our profession, who did not have the fortune of learning science and literature. So I do not blame them ever. Pallavi was talking about me being on panels for insurance companies. I do not um, testify against a dentist ever because they did not have the fortune, the privilege of learning this. But then again, ignorance is not an excuse. So please look up literature, learn from a good program. How can you avoid these type of tragedies? And when it's a patient you're looking at, the tragedy is just a tragedy. When it happens to yourself or your son, daughter, mom, dad, sister, husband, wife, it becomes a catastrophe. That's when we really wake up. So, non-odontogenic toothaches. A nice flavor that I have within my little education in this field that Pallavi was talking about is that I do have some more education in what's called sleep medicine. And I was fortunate to learn it from some of the pioneers in sleep medicine, such as Dr. Colin Sullivan, who actually invented the mask that treats this. So, snoring and sleep apnea is high on my agenda, and the connection with a lot of other things, sleep and pain, for example, sleep and orofacial pain. I showed you that slide that is my plenary session that I will be, God permitting me, will be doing this few months at the session of the plenary session of the AAOP. Systemic factors in orofacial pain. For some students who have looked at this, they say, "Oh my God, it's a lot of systemic factors." That is the truth. If you disconnect your face and your head from the systemic factors, and that is not looking at nerve and muscle in some type of an appliance that you connect and you read off a graph. That's not what I'm talking about. What I'm really talking about is what are the hidden systemic factors, and there is probably 100 of them, maybe more. All you have to do is open the old book that we used to have in the second year. Robbins, Daddy Robbins, we used to call them in Manipal. You just need to open up those pages and see the flavors of life that that book represents. If we think for a moment that is, oh no, that's not the teeth and the jaw, and it's not connected to TMJ, TMD, or official pain, we would be wrong. So I have incorporated a large part of systemic factors in orofacial pain in my programs, including with the Smile USA 150 and 400 hours, and that is going to stay there and maybe even get more. Because the last thing I want is one of my students inadvertently missing this and causing to hurt a patient, such as that I see in our dental community, not knowing. So I'm not going to blame them. But again, ignorance is not an excuse. So we must learn this. And there are others. And then I'm a researcher, both clinical and basic science. I do tend to work on rats and mice. I do tend to go away a little bit from the trigeminal and the facial nerve, such as the sciatic nerve. I like it. And that's crazy me. If one of you or many of you listening to this, uh, you think, oh, wow, let me look at that option too. Let me expand my horizons a little bit. You're welcome. And I'll be more than happy to uh, either direct you in the right direction or mentor you. For an untrained dentist, and these cases have been worked up with occlusion like multiple times with disastrous results. I mean, this is a transition from an unluck or misfortune to a catastrophe. This is the type of case we do see every single day. And we do this and say, what are we thinking as a profession? This patient might have seen, not might have, has seen multiple dentists that tended to correct the bite, that tended to think that they knew the diagnosis. I'll give you the diagnosis. This was pre-trigeminal neuralgia proceeding to trigeminal neuralgia. But if you miss that first part, pre-trigeminal neuralgia, you missed the bus. You missed the station already. And that knowledge does not come with certain programs that will teach you how these wires should be connected into the patient's head. If you could connect the same wires into the patient's brain, then I probably will look at the data, but not the face. That's proven so many times that that's nonsense. So look at the literature, please, into cases like this. This is a tragedy that every dentist who sees this case after the first, the second, the third, fourth, fifth thinks I can do better by the same lack of education that I had. And that is why orofacial pain is a specialty. This is a tragic case, but there's hundreds and hundreds of these recording every single month that we get. I mean, this is nonsense, but this is my mentor, Dr. Elias, so the courtesy to him. When do we stop this type of stupidity? That's what really gets me sad, that there is the science out there, but then, as in this case, probably all the teeth are ground down to nothing. There is no bite in this case, in addition to 28 root canals. And there's a valid reason there is no 29 or 30, 31, 32 root canals, because the four teeth were missing. That's the only reason. Otherwise, probably that would have continued too. So when do we stop? What do you see here? Multiple root canals done on the upper left side. I know, Pallavi, you are an endodontist, I think. Um, what education do we have to see a case like this? And are these rare entities? The answer would be no. And to the endodontists out there, the literature is clear, 3 to 6%. And some of the literature goes it above it to 13%. And you're talking about randomized clinical trial controls. Okay, so it's not just one case study. It's not a single case report, multiple studies. And we know this for a fact now, that let's say 3 to 10%, average, let's say even 5% of root canals either start with non-odontogenic causes or end with chronic pain. Why? That is the science I implore you to learn. By the way, that case was a cluster headache case that refers the pain to the maxilla and the teeth. So, what would you tell this patient as a cognitive, as a very truth abiding clinician? What would you tell this patient? Ms. Jones, your root canals were done, one was extracted, we were planning a implant, but we did not know. We're sorry. Well, too late for sorry in this case, because this is a catastrophe for this patient and an absolute injustice. So if you do not know at this point, for all this you're listening in India and other countries, refer to, if you think there is even one iota of doubt in your mind that it might be a TMJ case, TMD case, or a facial pain, maybe a headache, maybe some type of pain you don't understand, you have people now that you can refer to. And in India, there is a robust group of people that I have myself mentored a little bit, and they're coming up with flying colors. They'll be your referral base for this type of cases. They can teach you also these type of cases. If I look at three beautiful women and I know that one of them has a TMJ click, TMJ pop, and is being treated by multiple dentists, by multiple appliances, putting their head connected to so many scanners and scammers, and they don't understand that that thumb that is hyperflexible in that middle, these are assistants. So one of them, they are in the field, they are in the medical dental field, but no one asked about that thumb right there. She's hypermobile. Is there any doubt in our minds that if you have systemic hypermobility, for example, of all of you sitting out there today and listening to this, is there any doubt in your mind that if all joints are hypermobile, what are the chances that the TM joint will not be hypermobile? See, this type of knowledge is what I want to bring it to you in India and other countries and robustly look at these cases. Stop putting appliances in their mouths if you don't know the diagnosis. That's what my message to and my humble request is. Do not hurt these patients. The best scanner you can get is your own brain. If we are not activating this within our community, within our dental community, if we don't activate it, like in the United States, they say, we'll have a sucker sticker stuck on my forehead. This patient has been through multiple dentists. All of them made her believe that, okay, my appliance will work better. My tooth adjustments will work better. My scanner that I'm going to do is going to be miraculous. And guess what? Disastrous. She does not have a bite anymore, by the way. So please let us stop this type of nonsense in our profession. So, how do you become, let's say, an OFP, not specialist, but trained? Learn more from a course, document your C, continuing educations. Look up websites like American Academy of Orofacial Pains and International Association for the Study of Pain. That's the largest umbrella of evidence-based pain management. Do not let physicians look at us and laugh. Let us stop this nonsense, right? If IASP, International Association for the Study of Pain, that's the largest umbrella of 25, 30,000 physicians in pain management from around the world, are saying to us, we accept you as our colleagues. Stand shoulder to shoulder with us, lecture with us, present with us to us. That's a privilege to dentists to do. And the same to them we give. Physicians, we ask them, rheumatologists, physiatrists, physical therapists, psychologists, psychiatrists, we tell them, neurologists, neurosurgeons, we tell them, be our colleagues, stand shoulder to shoulder with us, lecture to us, lecture with us, learn from us, and then we are ready to learn from you. This is the beauty of organizations such as IASP. Please look up those organizations. And there's one organization that I know of, that the International Association for the Study of Pain, they define pain for around 100 countries. India is right with them. All neurologists, neuroscientists, pain and palliative care anesthesiologists, they converge in this huge platform every 2 years. Why should dentistry be different? We make a big deal out of this TM joint. Oh my God, that joint is without which you will die. No, no one dies without a TM joint. They survive. But let's do science and evidence-based thing that we can really help these patients out and flourish in our field. We don't have to scam them. We should not scam them. We should be asking the question, where does this data come from? And that is what I'm imploring you to do today. These are bizarre cases reported from India and elsewhere. My student in the mastership program, Dr. Vaishnavi, brought me a case. And I'm looking at it and I'm saying, something doesn't add up in this case, right? We did the diligence. Two dentists do the diligence that 10 other specialties did not do. And I'm not mentioning any specialty here. Of course, this patient would have gone through bite adjustments and whatever scanner you want to put on the patient's head. But in the end, this case turns out to be a Parkinsonism disease. 17-year-old New Jersey patient. These are not exceptions. These are not vibrant oh my God moment, because we're so numb to seeing these cases over. Some of them are more extreme examples, like Vaishnavi's case, for example, that came from Chennai. Second case, 17-year-old New Jersey male. Patient died by the time it could come to any of us. And of course, it was treated by occlusal adjustments and all of the nonsense that came with it. Occlusion causing TMJ, TMD issues is old. It is really not, at least for me and the 15 years that I'm looking at this, hundreds of other researchers, not just taking my colleague dentists and say, let's come up with something. And believe me, in my conflict of interest slides, I said to you, I have nothing to sell you. The only thing I have to tell you is about my program, which if you want to take it, it's a commitment of not 2 weeks, approximately a year. That's the family we built up. And for the mastership course, it'll be like 2 years commitment. So look at these cases. Headache in an 82-year-old patient. The second patient was a tumor of the brain, and he expired. He died 5 months. Female. These are recorded, published cases now. What was the thing? Oh, bite adjustment, this, that, all the nonsense. And then you find out what? Oh, it was a pituitary tumor. What? Yeah, because these cases come to you and present to you with all of us as TMJ cases. They're not. Kerala, my student from mastership program again, Dr. Prisley Thomas. He's not related to me, but he's a great physician. He brought me the case, and then we sat together with it, bust our brains on it, and we said, what is this, a TMJ case? No, we went up a little bit higher, and we said, oh, maybe it is giant cell arteritis. You ask dentists who ask you to connect the patient's head to a scanner, what is giant cell arteritis, by the way? Oh, I don't know. Well, you should probably, right? Because these are not that rare in India, 1.3 billion people. Not in the US either, it's not rare. 350 million here. Giant cell arteritis, we thought. And it was not. It blew our heads off, but because two dentists, with the help of some other professionals who believed in us, Dr. Prisley and myself, we had a team, interdisciplinary team, multidisciplinary team that looked into the case and came up with an explosive diagnosis, which is now going to be published as an invited review in a neurology journal. Can you believe this? That's the beauty of science, literature, and evidence-based dentistry. 13-year-old female, orthodontic treatment is what is being suggested to her. For what for? Open bite, anterior open bite. To the orthodontists out there, if you see an open bite on a 13-year-old female that developed over the last 1 year, please do not look at tongue thrust. This was the diagnosis from two orthodontists, tongue thrust. So we're going to correct that by habit-breaking appliances. But what if I tell you this poor little girl does not have both the condyles anymore of the mandible? Is it that rare? No. We see these cases probably once a month now at Rutgers. Understanding, yeah, it's a tertiary center. But my message is this. If you have one patient going through this in your practice, one patient, it is worth the education, the time, the money you spend on something learning like that. That's my message to you. Organizations you should know that really based on science and literature. IASP, American Academy of Orofacial Pain, American Academy of Sleep Medicine, and we just formed, but it's going to be vibrant more for the Eastern Hemisphere. We are forming a new one. It's registered already with myself and Dr. Iyer. So look out for those updates on that. You will get knowledge, not something that I can sell you with. The tragedy of dentistry is this, that our education in all our dental curricula all over the world, including the United States, it sucks. It is grossly insufficient. The system has been inefficient until now. Until now, we have a specialty. And we always say this joke. Out of all those dentistry, zero. Most of the schools that I've watched when I visited India, and I've asked thousands of students, they fall in the 0 to 5 hour range, if they do, of pain management philosophies being taught. Same thing here, nothing different. In USA and Canada, average dentists get 15 hours. Look at the veterinary medicine, they are much better. The joke we have is if you have a toothache, you go to an animal specialist because they understand pain. Average 87 hours they get. That is how pathetic our pain education in dentistry. And that's why this is a specialty. At least in the US, it has been in Brazil, Israel, Canada, the US military. It's been a specialty and it's catching up. And so should India, robustly. We have the solid brains there. Quacks will be everywhere. That's in India, US, all of the stuff. But we have brains. We have that science attitude in us. So I implore you to look up this type of education that is literature based. PMDs are amazingly complex sometimes, but understand it is not the mountain you cannot climb. It's nothing like that. It's a systematic workup. When I teach, with all humility, I'm saying cases that the students bring me, some of them humble me, many of them humble me, and I'm ready to be humbled with that one. Not when a student says, but I heard this from the other one. I really don't care. You look up the literature that I'm giving you or AAOP people are giving you, look up the literature that somebody else gives. Literature. And by saying literature and science and evidence, I don't mean the literature that I published. That's a conflict of interest. I'm okay. Don't look at my literature, right? Look up the literature that hundreds of other accepted by who? IASP, AAOP, that type of published literature. The data is out there. For all of you specialties out there right now, there are 11 more specialties other than ours. So let's talk to the 11 specialties and say, hey, listen, you look this up, please help us. Let us help each other out. That's the principle. Anatomy of the TMJ is the least that we teach in dental schools now. It is pathetic. There's some monotonous lectures many a times, and yeah, okay, moves TMJ moves like this, muscle that, and the essay type question, and you're finished. But that's not what you see in real practice, right? In the real practice, there is a lot more of these flavors of life that will come to us. So I think this is the most underserved area in dental education at this point. Every other branch and the new batch we just started, the new batch of students, the global fellowship program we started, all specialties are represented now. People have joined from all quarters in India, from Israel, from other countries, they have joined. And we're looking at them and we are saying, oh my Lord, this is successful. Why? All the specialties have joined into this and say, we accept you as a specialty. Teach us what we don't know. But in return, I'm going to ask the 11 specialties to teach me what I don't know. Well, it's a bi-directional. It's a bridge that there's a two-way bridge. And I love it that way too. So there's so much to be learned about TMJ beyond this one diagram. Diagnostic tests. We all want to do diagnostic tests. So what is the standard of care for diagnostic tests? Please go into the literature. There is robust, amazing literature that has come out. If you want to look up RDCTMD, research diagnostic criteria for TMD, and it's a big one. And then there is clinicians, you can use a little bit of this, DCTMD, diagnostic criteria. RDC is for research, DC. Even that is, for me, it's not that practical because it's long, but you'll get a solid diagnosis coming out of it. But we're going to streamline that the way that myself and other teachers teach. We streamline it as much as, again, evidence and literature based. Not in my hands. I don't care what works in my hands. Some people say, in my hands, this worked for 15 years. Let's stop saying that I did something wrong for 15 years. It apparently worked. And now I'm going to call my mistake experience. Let's stop saying that. Let's see if it works for the 300 other patients, 3,000 other patients, similar diagnosis. Let's see controls. If I didn't do this procedure, if I did not adjust that cusp, which I thought was an interfering cusp, interferences that we can trim some magical way that will correct and prevent TMD. What type of nonsense is this anymore? So let us step back without doing an irreversible procedure on that patient. Let's step back, read some literature, and say, maybe I should do something reversible. So please, and bring it upon yourself to learn a little bit more. I will do my little, but you guys can do much more than what I've done. Role of occlusion in TMD. This has been a big hoopla all around the world, and a lot of them are recognizing that it is not in TMD. Occlusal principles are gold for protecting what we are doing for the patient in terms of reestablishing the bite. That you can ask any really savvy orthodontist, savvy endodontist, prosthodontist, reconstruction specialist, implantologist. Occlusal principles are gold for protecting the patient's interests, financial and otherwise, and our interest in what we are recreating for the patient. Not to prevent TMD and not to treat TMD either. Where has it been published is what you need to ask. The next time somebody tells you, oh, use this equipment and adjust that teeth, or retrain the muscle. What are you talking about, retraining the muscle? What is the literature? Where was it published? Well, it was published by Dr. Thomas in DT Journal of Dentistry. It doesn't really care because DT is myself, Davis Thomas. I'm publishing my own study in my own journal, right? Or 100 of us get together, we do some botch studies, we publish and we quote each other out. That's nonsense. So let's look up the larger picture of accepted norms by IASP, by AAOP, that type of organizations. And there is a lot you could learn for yourself and mainly for the benefit of the patients that come to you. What is the best occlusion if you're trying to adjust occlusion? Well, it depends. What does it depend on? It depends upon the floor of the university where whatever department is there. Perio might define it a little bit differently. Oral surgeon, I think they might say whatever you guys want to define it, because we do surgeries mostly. Orthodontist, to my orthodontist, I'm asking you, how many bites have you changed in your entire lives? You start your profession by changing bites. The moment you put a loop or wire on, you change that bite. And that's the best thing you could do. It's excellent. It's amazing. But if somebody tells you, hey, bite changes will cause TMD, will your profession even survive? I don't know. I'm just asking the orthodontists out there. I've asked the same question here. Now I'm asking the world population of orthodontists, is there any truth in that? No, you change bites successfully, robustly, based on evidence and clinical medicine that you know. And nothing happens to those patients. They're absolutely fine over 6 months. Some of you change it 3 months, 6 months, year, 2, 3 years of bite change. And at the end of it, they have a beautiful smile, aesthetically and functionally pleasing. So what happened? We changed the bite and they were normal all those 3 years? Of course they were. That's the beauty of orthodontics and any other reconstruction ones. However, when we're doing a reconstruction with bridge and multiple implants and all this stuff, we need to follow the principles of physics that have been embedded in the rules and regulations of occlusion. That is beautiful. But to teach a student who has a fresh brain looking for something new, oh my God, this occlusal abnormality is going to cause TMD. What type of nonsense is that? As a matter of fact, the class 1 bite that we all love to see, that beautiful smile that comes up. I was looking at when I was being introduced. Pallavi has a beautiful smile. class 1 smiles that I'm looking at, if we go and change that, especially in an already existing TMJ muscle or joint case, you're going to get married to that patient because that's the worst to correct. Not class 2s, not class 3s. So take it with a pinch of salt when somebody says class 1 is the best. Not so. And it has nothing to do with the TMD part of it. It might have to do with the rest of the tissue. And that is where the knowledge should come. Let's not learn from machines. Let's help make the machines just help us. That's it. And we don't need an EKG machine on your head to know, or something like that scares the hell out of the patient. We don't need that. We do need a scanner, which is what? That's called the cerebral hemispheres on both sides of the head. That's what we need. We do have it in abundance. God has been very great to us. But to expand that and entrench in it knowledge, that is up to us to decide. So what is the best occlusion? There's none. So why then this group from New Jersey, or the group from Delhi, or the group from Las Vegas, or Florida, or California, or Seattle group, or this group, that? Why are we having different types of concepts even? This is why medicine looks at us and laughs. They tell us, you little quacks, what are you doing with this? So we need a consensus. And that is the American Academy of Orofacial Pain, which I'm proudly, after so much thought process and so much education, proudly a member and a fellow and a diplomat of. So please look into literature. Role of occlusion TMD is mostly debunked. Let's stop hurting these patients based on this, please. Little evidence as a primary etiologic factor. Then somebody said little evidence primary etiologic factor for TMD except posterior support. May I ask you a question? What does Europe go by these days? Whole of Europe for posterior support. We said missing the third molars will be, oh my Lord, I can't imagine that. Missing the second molars, oh God, that's going to be a horrible thing. Missing first molars, oh my God, we believe in occlusion, so first molars missing, you are screwed for life. Not so though, because much of Europe is going in the direction of what? If you lose your teeth, only reconstruct it premolar to premolar. What? What happened? Until 1987, centric relation was supposed to be the most posterior superior position. 1987, something magic happened. When I joined dental school, magical happened. The prosthodontic terms, glossary of prosthodontic terms started changing for the right reason. It was not posterior superior anymore. It was the most anterior superior position with the condyle resting on the posterior slope of the anterior eminence. What? Yes. It switched from diagonally opposite to the diagonally opposite. Did those patients die? The ones we treated with centric relation in those days? No. They survived. How did they survive? Well, look at literature. And those prosthodontists out there, you guys are amazing, amazing. But the moment we think we are going to correct that bite to prevent TMD, we went wrong. To treat TMD, we went wrong again in 99.99% of the cases. So do you have to buy 100,000 rupees appliance for that one case that you don't even know? I don't think so. Occlusion, molar to molar, third molar to third molar, second molar to second molar, first molar to first molar, premolar to premolar. What is it? What do we want? There might be some perpetuating factors. I'll tell you, I'll nail my students on systemic. Out of the 31 master's candidates that we have now, at least one or two might be thinking, I'm fed up of systemic factors. Well, too bad, because that is medicine, right? I'm saying they might. Out of my 150 fellowship students who have graduated, at least 10 of them might think, systemic factors? No, no, no. I'm going to adjust the bite. Have fun. But in these programs, we are going to treat, and we are going to teach and expect you to learn systemic factors first. Do not look at the teeth first. Look at the patient first, right? That's what the physician should do. If you go to a physician saying, I have a lesion on my skin, the moment he treats that without looking at your medical history and what is happening in your laboratory values, he fails. Why should dentistry be different? Because we're trained by some quacks also to look at, unfortunately, just the bite, and here is my little appliance that you can use to correct that bite. That's wrong. As much as I humbly can say, that is wrong. Diagnostic tests, we need to look at reliability, validity, sensitivity, specificity before you invest. And there is so much literature that has come out of these jaw tracking devices, these other devices that look into your muscle, the tooth contact, and all that stuff. And there is abundance of literature from the 1990s to now saying, what type of nonsense is this? Is what is it saying? Read literature, then decide what philosophy do you want to develop in your practice. I'm not going to elaborate on this. There's literature after literature after literature. However, evidence-wise, you look at evidence, specificity and positive predictive values for these kinesiographs, they call them, were found to be well below accepted standards. And that's the key, below accepted standards. But the principles of medicine are way above and are the accepted standards, always. Use of these devices in the diagnosis of myofascial pain, that's what they say now. Muscle, myofascial pain, connected. Fails to meet the standards of reliability and validity for the usage. And this is not one or two studies, this is multiple studies. Hence my point, there is a new sheriff in town. Look up the principles of science that American Academy of Orofacial Pain, or ask them. I'm just a humble part of that organization. They have much higher, more vibrant people in there, very robustly published. Hundreds of them are there. Ask them for help, or take a course that will teach you structured and systematically. Ask the colleagues that are graduating from India, for those of you who are from India. Those are our students coming up with solid knowledge, evidence-based knowledge. Ask them, what is evidence? Look for evidence, please. And I always quote my friend Dr. Iyer's words on the bottom there. Do you want a 50-cent articulating paper? I'm quoting him, and I'm completely in agreement with what he says because it comes from both of us now. Do you want a 50-cent articulating paper or a $50,000 articulating paper? Means that scanning stuff that you can do. I would take a 50-cent articulating paper and save the agony and the insult that comes with the other one for the patients and for your profession. That's my plea. That's my plea to you. I'm going to stop here. And I think it is now at the 10 o'clock mark. So I'm going to let Dr. Sonal, who is my student in the fellowship group that is going on now. She's a robust clinician, amazing lady. And she's going to start her little presentation in line with, I think, what I told so far. I'm going to mute myself. Pallavi, can you hear me?
Yes, sir, I can hear you.
Okay. I'm going to stop sharing, I guess, right?
Yeah.
Sonal, you're there, right?
Yes, doctor. I'm there.
I'm going to mute myself for a quick moment, and you take over, mentee.
Yes, sir. Yes, doctor. Thank you.
And I'll be with you. If you have a
Yes,
question or a comment that I need to make on any of those, please feel free.
yes,
In
doctor.
other words, you're not a runaway train, okay? Just feel free to make me join the
Yes,
party.
doctor.
No problem.
Yeah, Dr. Roxon, can I share my screen now?
Yes, ma'am, you can. You can open your PowerPoint, ma'am. It's already shared.
Okay.
Don't close this.
Yes. Okay. Am I audible? Hello.
Yes, Sonal. Beautiful picture, by the way.
Thank you, Dr. T. Hello, everyone. It's a privilege to be a co-presenter with my mentor, Dr. Davis Thomas, and it's always humbling to learn from him, I would say. And I would take this opportunity to thank Dental Digital Conference for this amazing platform you guys have presented, and Dr. Pallavi for the introduction. And again, kudos to the team, Dr. Roxanne, Dr. Nupur, who have been wholeheartedly managing this conference very well. Okay, since Dr. Pallavi has given a good introduction about me, I will just like to add certain things. I'm Dr. Sonal Yerpude. I'm a private practitioner from the city of Dreams, Mumbai, that is placed in India. I've been into clinical practice for the past 17 years. I feel fortunate being a general dentist, as I was never confined to one specialty of dentistry. This gave me an opportunity to help patients with simple as well as complex and multidisciplinary treatment planning. After completing my graduation from DY Patil Dental College in Navi Mumbai in 2003, I have been in continuous learning process from various universities all across the globe, and currently I'm pursuing my fellowship under the guidance of Dr. Davis Thomas and Dr. Shankar Iyer sir. Okay. Over the years, I have witnessed that the most annoying clinical condition are the ones with complaint of orofacial pain or complaint of chronic pain or pains without confirmed diagnosis. This curiosity behind such unsolved chronic cases led me to my journey in orofacial pain. I was fortunate enough to be mentored by Dr. Davis Thomas, who made me unlearn many old concepts in dentistry, giving weight for new ones with evidence-based scientific approach. Some of the most prevalent and debilitating pain conditions we dentists witness arise from structures innervated by trigeminal system. Temporomandibular disorders are the most prevalent orofacial pain conditions for which patients seek treatment. Together, these conditions of trigeminal system impact the quality of life of the sufferers dramatically. A multidisciplinary pain management approach should be considered for the optimal treatment of orofacial pain disorders, including both pharmacological and non-pharmacological modalities. Today, I am going to be speaking on orofacial pain from the point of view of a general practitioner. Whatever little I have understood in this past 1.5 years, I have been associated with Dr. Davis Thomas. The clinical anatomy and the red flags a clinician must be aware of, and when to refer to a orofacial pain specialist so that they avoid unwarranted or false implication of the treatment plan, whatever they are planning. The most annoying characteristic of pain is its ability to make its presence felt, and this is especially true when the pain becomes chronic. Chronic pain can be described as pain lasting for a period beyond the regular healing time. In general clinical considerations, we put it as pain lasting for more than 3 months. Chronic orofacial pain limits the person's ability to chew or jeopardizes the individual's activity and can become a life-altering phenomenon. The above picture, known as the homunculus, is a graphic depiction of functional area of sensory and motor cortex, 45% of which is dedicated to face, mouth, and oral structure. This emphasizes the importance of this structure to an individual and making the pain felt in these structures more meaningful and personal than the pain felt in any other part of the body. Your work as a clinician starts right from the time the patient walks into your practice. Be aware of the patient's overall physical appearance, gait, body posture, physical symmetry, and I would say systemic history taking is the most important step towards planning or management of any individual case. Every detail is important, as Dr. Davis Thomas has just specified. As it is said, the eyes cannot see what the mind does not know. It is true and while dealing with any clinical conditions. To begin with, let us just understand what orofacial pain and how it is classified as. It is the basic classification under the axis 1 and axis 2 of orofacial pain. We can just simply put it as somatic pain, orofacial pain related to the somatic structures, neurogenic structures, and psychological causes behind the orofacial pain. The orofacial pain can be Now, understanding the orofacial pain classification, let me just take you through a sneak peek into why the orofacial pain condition shows such confusing clinical findings. We dentists have traditionally received excellent instruction regarding the trigeminal pathways and their significance in the orofacial pain complaints. Afferent facial sensory information such as thermal, mechanical, or nociceptive impulse reaches the central nervous system through the fifth cranial nerve, synapsing mainly in the spinal tract subnucleus caudalis. After also synapsing along with this trigeminal nerve are or converging in the subnucleus caudalis is the primary order afferent information from facial, glossopharyngeal, vagus, hypoglossal, and the first three cervical nerves. This convergence of multiple cranial and cervical nerve is one of the explanation for referred pain, where the pain site and the source may differ. The theory of convergence of nociceptive inputs can lead to confusing diagnostic presentations, and a clinician must be well aware of the nerve anatomy and pain pathway to reach to a proper diagnosis. We as clinicians will come across certain clinical orofacial pain characteristics shown in patients having orofacial pain complaint. Hyperalgesia, that is increased response to a stimulus that is normally painful. Allodynia, pain due to stimulus that does not normally provoke pain. Paresthesia, abnormal sensory sensation. Dysesthesia, abnormal and unpleasant sensation whether spontaneous or evoked. Once you understand these characteristics, you can easily identify these conditions in patients. Dr. T, I know that you have been emphasizing on for us to find the difference between these characteristics shown clinically. Can you elaborate more on the same topic for me?
Yeah. When just a small clinical pearl for those who are listening, if the patient says that I have TMJ problems, a dentist has told me this, or somebody else has told me this, and I feel my lip or tongue numb along with my TMJ problem, take that as a high level priority case. Numbness does not come with TMJ problems. Numbness comes with predominantly one thing, that there is something happening to a nerve somewhere in that course. If it's a lip, from the lip all the way to the central nervous system and the nucleus, between there somewhere. So please take that seriously. The tragic cases we have seen of people's heads being connected to appliances and this and that, and then going through 15 different dentists and ending up either as a disaster or a catastrophe or ending up dying, that's because somebody on the way did not ask for what Sonal is now referring to, paresthesia or dysesthesia in any of these areas. Do not take that lightly. Don't start adjusting teeth, please, in those cases, because you will see a patient kick the bucket right in front of your eyes or in somebody else's clinic or at home, and God forbid they track it back to us that treated these cases. We are responsible. So I just want to add that. Thank you, Sonal.
Yes, sir. Okay. As described by Dr. Thomas, certain neuropathic pain conditions can become life-altering phenomenon for patients, and trigeminal neuralgia is one such condition which we clinicians will come across commonly in our day-to-day practice. The term neuralgia means pain in the nerve. Trigeminal neuralgia, also known as tic douloureux, disorders of trigeminal nerve that causes paroxysms of unilateral intense stabbing, shock-like pain along the distribution of trigeminal nerve in the orofacial region like lip, eyes, nose, scalp, forehead and upper jaw or lower jaw. Pain usually lasts for few seconds to less than 2 minutes and is often elicited by monetary stimulation of trigger zones. Trigeminal neuralgia commonly goes through a period of remission where the pain can remit for months or even longer. The etiology of trigeminal neuralgia is often related to vascular compression that may result in focal demyelination. The superior cerebral artery compresses on the trigeminal root has been shown to be responsible for the attack of trigeminal neuralgia pain. However, non-vascular compressions have also been shown to result in trigeminal neuralgia attacks. Dr. Davis Thomas, sir, generally asks whenever he is teaching us in normal lectures or day-to-day practice, his emphasis is more on the referred pain or the pain referred from the muscles. And we, as clinicians, have also seen over a period of time in our clinical practice that the pain referral pattern that is shown by the trigeminal trigeminal nerve system is of a very unique way. And I would like to highlight certain rules that a clinician should know when they are dealing with referred pain. Referred pain most commonly occurs within the single nerve root passing from one branch to another branch. Pain is referred always in a laminary pattern. Referred pain rarely crosses the midline. Example, pain from right TMJ will rarely cross over to the left TMJ. If the referred pain is felt outside the nerve that mediates the pain, it is generally felt cephalic to the nerve, that is upward towards the head and not caudally. Referred pain can be confusing to the clinician and as well as the patient. Treatment provided at the site of the pain where will not arrest the pain and can give frustrating results to the clinician. So be aware where the site of the pain and the source of the pain is. These two can be different in the case of referred pain. The most common cause of discomfort in orofacial pain is because of pain from muscle origin. Myogenic pain of different types may involve muscle of mouth, face, and neck, with the symptoms complexity depending on the kind, number, and location of the muscles involved and the degree to which they are affected. Myofascial pain is characterized by regional dull, aching muscle pain and the presence of trigger point in muscle, tendons, or fascia. During clinical examination, the muscles of mastication are palpated bilaterally to check for pain or tenderness to palpation and pain referral. The clinician may also palpate for myofascial pain trigger point, which are hyperirritable site in taut bands of muscles. Where palpated, these trigger points may produce a characteristic pattern of pain referral or show some autonomic features on provocation. Types of masticatory muscle pain. Protective co-contraction. This is the first response to any traumatic event limiting the mouth opening. No pain is reported during this protective co-contraction, but increase in use of the muscle can increase the pain. Local muscle soreness is it's myogenous in nature and is actually a response to prolonged co-contraction and usually non-inflammatory. Myofascial trigger point pain that originates in the local muscle tissues. Myospasm, that is centrally induced tonic muscle co-contraction. And chronic centrally mediated myalgia or fibromyalgia. Dr. T, would you like to elaborate more on the muscle referral pattern and the pain from muscle origin?
Sonal, the only thing I wanted to say is that you presented this so wonderfully, and I would just add one thing to that what you're saying right now in the same line is that I wanted to say that most of the horrible mistakes that I see done to patients by the lack of knowledge, especially in this field, is secondary to the fact that it's referred pain. For example, patient points out to the front of the ear for the untrained dentist, oh yeah, it's the TMJ. But understand that maybe medial pterygoid or lateral pterygoid can refer that pain there, or maybe something else can refer. Maybe the upper trapezius can refer to the angle of the jaw. Looks like the TMJ, a problem. And without proper workup of the case, such as what you would do, Sonal, or any of our students would do, this would be a disaster waiting to happen. The second thing she has shown, these slides are amazing. I think I'll ask you for these slides with your permission that I can use with courtesy to you.
Yes, Dr.
Fibromyalgia is so becoming prevalent, not just in US, but in India too. If you connect that patient's head to something, I don't care what appliance or what device you connect it, nothing has become normal. And to treat that case of fibromyalgia, for example, one of the cases, one of the differential diagnoses that Sonal has so nicely put on this screen now, if you try to treat that case with an appliance and with adjusting the teeth based on something that a machine told you, you're going to just look at a phenomenal failure and a disaster or a catastrophe waiting to happen, not just in the first dentist's hands, but the subsequent dentists who all think they can do better this cascading, this ball rolling, and let's step back and learn this first and then go forward. But these slides are really good. I have no slide like this. I would like to have this. Thank you, Sonal.
Okay, sir. Okay, moving on, we'll talk about TMD first. Temporomandibular joint disorders, the most prevalent conditions of which the patient will seek treatment, and careful evaluation of this facial structure in conjunction with clinical symptoms is crucial in forming a proper differential diagnosis and planning for a dental treatment. Temporomandibular joint disorders defines a number of clinical problems that involve the masticatory musculature, the TMJ, and the associated structures. Pain that emanates from the structures of TMJ display the characteristic of deep somatic pain. Mostly, those pain are musculoskeletal. Pain in pain is intimately related to masticatory function, and the degree of pain is proportionate to the amount of function or manipulation or manual palpation. TMJ disorders can be classified on the origin of the pain in form of pain of muscle origin, internal derangement of the joint, or pain from degenerative joint disorders. Temporomandibular joint derangement, I think Dr. T has elaborated already on this topic very well. The temporomandibular joint disorders, signs and symptoms, what clinically clinician will, what TMD will represent has the characteristics of headache, clicking or popping of sound in the jaw lock, difficulty in opening and closing of mouth while chewing or yawning, or pain while chewing or yawning, tenderness of jaw muscle, or any it could be as benign as fullness of the mouth, or maybe a pressure felt by the patient will represent with all these kind of clinical structures, and you have to be vigilant enough to identify these painful conditions of temporomandibular joint disorders and differentiate them from any other odontogenic or if they have an odontogenic cause or a non-odontogenic cause behind it. So you have to be very vigilant for this. Role of TMJ, role of occlusion and temporomandibular joint disorders. Actually, Dr. T has already elaborated quite a lot on this, and I would like to add a few points which I have noticed over a period of time as a clinician and practicing as a general practitioner. Occlusion is the foundation of dentistry. Its stability is the basic of masticatory function. Role of occlusion as cause of TMD may not be the same in all patients. That's what I have understood. Up until few decades back, occlusion was considered the most contributing factor in TMD. Recently, many researchers, as Dr. T has mentioned already, argue that occlusal factors play little or actually no role in TMD. Occlusal contacts pattern will influence the precise functional activity of, and the old concept of certain tooth contact causing parafunctional activity have also been disapproved by researchers all over the world. Clinically, we can notice special occlusal contact patterns can influence a specific muscle group causing these conditions causing these conditions. And generally, I have noticed that these conditions are self-limiting, and clinicians should refrain from doing some permanent damage altering the occlusion. TMD is a collective term embracing several clinical problems that involve the masticatory muscle and the temporomandibular joint. The pathogenesis of TMD is not dental related but is a part of wider family of orofacial pain disorder, which accounts for need of certain considering the neurological, endocrinal, physiological factors behind during the diagnostic planning. Occlusion, condyle position, and lack of canine guidance and are not that primary while considering the causes of TMD. That's what is my understanding, and as well as the research work that has been published all over the world. TMD signs and symptoms are often resolved by conservative and reversible therapies. So refrain yourself from grinding of those cusp or those angles or changing away the total occlusion when you notice a TMD case. Be a little conservative here. And Dr. T has already elaborated quite a lot on this topic. Dr. T, would you like to add one more topic on the same?
No, I love the way you said the principles few decades back. Yeah, it's more than a few decades back. So
Yeah.
that's good. It's quite a few decades back. Those are the principles that a lot of us stick to. But again, those are principles that are gold for reconstruction and the physical principles of our restorations, not to rule out or not to prevent TMDs, not to treat TMDs either. Thank you, Sonal.
Yes. So now, talking about TACs or trigeminal autonomic cephalalgias, we clinician will definitely. It's not. Believe me, when I started learning about this orofacial pain and everything, and I came under the mentoring of Dr. Davis Thomas, sir, I used to think, will I get a patient with cluster headache or hemicrania continua, or will I be able to diagnose this? Believe me, when you read through it, when you start diagnosing, when you start seeing these conditions, you will be surprised at how many conditions you have misdiagnosed, or how many conditions or how many cases you have not even ventured into. You have just missed those conditions, and you were just blindly treating the only the odontogenic cause behind the patient's complaint. Now, this trigeminal autonomic cephalalgias are a group of primary headache disorders characterized by unilateral head pain that occurs in association with general prominent ipsilateral cranial autonomic features. TACs, as we call them, can be as there are four actually if we start talking on TACs, it will take at least 4 or 5 days just to mention each and every part, whatever names are you are seeing here: cluster headache, hemicrania continua, for paroxysmal hemicrania, scunt or suna. All these features are very much clinically present. We as clinicians need to have that vigilance. We need to have the knowledge to identify such cases. Clinically, the syndromes can be distinguished by the frequency of attack of the pain, the length of the attack, and very characteristic response of medical therapy. The differentiation is important. This differentiation is important because each and every condition that is mentioned over here has different medical therapeutic therapies behind it and treatment plan. So that this classifies this trigeminal autonomic cephalalgia as a very specific headache group, and clinicians must be aware of. And as a dentist, we need to be aware of such conditions. Now let's talk about certain headache. Another source of non-odontogenic toothache and orofacial pain may present in the that may be present in the distribution of trigeminal system, that is migrainal headache. You will be surprised, and I have seen it personally in my clinical practice, that many patients of migrainal headaches refer pain to the teeth. So migraine is commonly known as a headache that is unilateral and that causes pain behind the eye, neck, and cranium. However, migraine headaches can also present in the lower part of the face, particularly in the teeth. It is very important that the orofacial pain clinician is aware of the possibility of this localization in addition to the clinical features of migraine present, to avoid misdiagnosis of odontogenic toothache or other type of orofacial pain. This can lead to improper management of the pain and primary pain, and give very sad results to the clinician, because we might treat a premolar or a molar which is where the pain is radiated, and actually the patient is suffering from migrainal condition. Primary headaches such as migraine or tension type headache are also disorders mediated by trigeminal system, and they are very chronic and disabling to the patient. It is known that headache and orofacial pain disorders such as temporomandibular joint disorders are highly prevalent condition in general population. Evidence suggests that clinical comorbidities between primary headaches and temporomandibular joint exist. It becomes paramount for a dentist to start bridging this gap between the odontogenic and non-odontogenic causes of orofacial pain and TMD, and have a multidisciplinary approach towards treatment planning and execution. Time has come, actually, I would say time has come for dentists to become an oral physician, so as to we have a systemic approach towards our treatment plan and plan our cases in a better way. Perhaps I would like to conclude my talk by saying that the most important clinical tip I would like you all to carry is that whenever you get a patient who's complaining of pain, listen carefully, consider all the possibilities, cure if you can, and manage if you cannot cure. But always console the patient. These patients have gone through hell. Actually, I have seen patients carrying files and files of dental treatments, or maybe dental practitioners. They have visited many of them, and at the end of the day, they are not yet satisfied with the treatment. They are still in pain. So the first thing you need to do is listen to them, console them. They are going to be fine. If you cannot treat, please refer them to a orofacial pain specialist. And again, a request request that this presentation or whatever you must have understood out of this lecture or whatever Dr. Davis Thomas and I'm talking, it is not a something that you can go and practice immediately. When you actually learn all these things clinically, or when you learn all these things undergoing certain programs, then only you can understand the depth to which this orofacial pain actually has impacted our dental practice. Me, I would say I'm still just at the tip of the iceberg. The iceberg is still below me. I have to learn so much still, and though it is just 1.5 years and for me into this orofacial pain practice, there is lot I need to learn. So don't consider the conditions whatever are mentioned above or whatever Dr. T was talking. Don't take them as a guideline and start practicing orofacial pain. You still need to have the proper knowledge for it, proper guidance, proper guidelines to follow, which will help you so that you don't get annoying results and you don't land up in an embarrassing situation. So I always believe that everyone of us has we are all followers of certain form of energy, and for me knowledge is the biggest source of energy. And from here, I would like to thank each and everyone in this picture, and also one more special mention, Dr. Satish Devarajan. He's a fellow from the master's batch of ours, and this is our OFP batch, fellowship batch, which Dr. T had mentioned. And I'm proud to be associated with each and every one of us. And Dr. T always calls our batch as a special batch. And I would actually love you all to know that each and every one of us are practicing orofacial pain, and we are discussing these cases amongst us, and we ourselves are seeing the difference in our practice. Everyone is every day there is one or the other case which we present to each other, and the difference that has created in our practice is paramount. I mean, you cannot compare it to what we were doing. With this note, I would like to again wish you all a very happy Diwali, since it is round the corner. Just 1 week from now, 1.5 week from now, it's Diwali time. And wish you all a very happy Diwali and a prosperous new year ahead. And with that, I would like Dr. T to continue, Dr. Davis Thomas to continue with his presentation. And thank you so much, guys, and hope this was you carried something good today from the lecture, what I talked about. Thank you so much.
I have to tell you, Sonal, amazingly presented, And I falsely believed for some time that you might be stressed out. And I just don't see that anymore. I remember the first presentation I asked you to do
Yes.
during the program, and you came after that and said, I was stressed out. No, today was just a flow. And I think this came from your heart and coming from a seasoned clinician such as you, and very, very classy little way of a student just giving a tribute to a mentor is amazing to see. So I really, really loved it. Thank you so much. And I'm sure the audience has taken it to heart, what the principle of what you were just saying. And it's so important to continue the road to education. That's what my message to is. So thank you, Sonal. Amazing job. But remember, I need a couple of those slides if you can at some point. With
Yes,
your
sir.
courtesy on the lower right, of course. I won't steal slides.
Okay, sir, doctor.
Okay, thank you, Sonal. I'm going to switch the screen to show
Yes.
something pretty simple, and we'll finish it off. I don't know if you need to share, stop sharing, or I'm not sure if I'm
Dr.
sharing the
Roxon,
screen.
can you make Dr. T the presenter?
Yes, sir. You need to start sharing it.
Okay, I'm going to start sharing. Roxanne, thank you so much. You've been amazing, my friend. You have done it phenomenally. You're guiding me through this process, so thank you. Let me see what I should do here. Share. And let me go here. Just let me know when you are able to see the full screen.
Yes, sir.
Okay. I hear some noises, maybe from somebody else, maybe a participant, I'm not sure. So anyway, clicking for joint noises. This is another thing that dentists wrongfully ask patients to get treatment for. Joint clicks don't need any treatment. It's just amazing how this pseudoscience have spread all around the world. These are the most common um, reasons for noises from the joint. And I will tell you, one of those that might bother me is the last point, where I'm talking about loose intra-articular bodies. We call it joint mice. They're not mice, but they're joint mice. And it's osteochondromatosis of the jaw, of the TMJ. Very rare, but I guess with India being a population of 1.3 billion with a B, you definitely will see this, especially in a 65-year-old or older, especially in a female. So the classic picture will be 65 plus female, and the jaw gets stuck randomly. And please don't use a scanner to check this jaw. That's not a scanning device that you need for this. This is really medicine, and you have to take appropriate imaging, look at it, and of course, in a structured program, you can learn a lot. At this point, understand out of all the joint noises that we can talk about, the reasons, that one is the only one that would bother me as a clinician because some of those particles, this tissue, the chondromatosis, might have a malignancy potential. So that bothers me. Otherwise, joint noises, no treatment. What do you do about TMJ, TMD issues? Well, avoid shortcuts. Refresh the basics you learned from physiology and anatomy. It's there. It's already there. Look for science, evidence, and literature and truth. In an evidence-based program, if you can, you enroll it like yesterday and find a good mentor, not a lecturer, not somebody that sells you an appliance or a device that he or she bought from somebody else, not a pharmaceutical company. They don't have any vested interest, I don't think, in any of you or your patients. They have no vested interest. They have one vested interest, which is in the US, we call it Benjamins, which is the $100 bills. India, you might want to call it Gandhis or whoever else is on the rupee bill. So get a good mentor. I will tell you, when I'm mentoring my students, I'm guilty as charged. I'm stoic. I'm a little bit army fashioned. That's what I am. I don't hide the fact that I'm that way. When you join the programs that we conduct, at least the courses that I'm course director for, there is no other choice. You can go to whoever you want, but I am what I am as a mentor. But I'll make sure when you leave the program, you have a sound understanding of the core fundamental principles that you will not be the reason of hurting another patient. And you will not be fooled by somebody who comes to you and says, this 200,000 rupee equipment will save your life. At least those two things I'll make sure. And I'll make sure also that you are proficient, not just reading it, proficient in the systemic aspects that can cause orofacial pain and general pain. Your keen observation is the best friend in orofacial pain. I don't want to bore you because Sonal has given a beautiful little rundown on this. I'm not going to speak to the choir again and repeat it. I'll be redundant. There are trigger points that you can delineate by actually really understanding how to palpate them, how to reproduce the pain. These are the medical errors that have been done tremendously, depending on how much ignorance a dentist has, how much misinformation that has been fed into those brains, and how many sucker stickers we have when we walk around. It's amazing. And these muscles refer the pain to the teeth. They have all the signs and symptoms of toothaches and teeth sensitivity, dental sensitivity, plus and minus, and they end up disastrously. Masseter, anterior temporalis, all of these. And on top of all that, I'm sorry for the overlap. This is because the ratio is changed. We do constantly what we call deafferentation. We cut nerves every day, injection or extraction, pulp extirpation, root canals. All of these are something to do with the trigeminal nerve. We do that all the time. Fortunately, when God created man, he had dentists in mind. So he or she said, trigeminal nerve, let it be perfect, let it be special. So all these procedures, these cuts and bruises we do to the face, ends up with no problem. But in 3 to 5% of the cases, let's say average 5 to 6% of cases, This might cause permanent change, or this might have come from a permanent change before. That is your focus, not the TMJ, TMD part. That's big. That's big. And there's a science to it. But the rest of it, just the nerve pain that Sonal was referring to, this you need education, solid education, to delineate what these structures, what these type of entities, where do they come from, how do you diagnose it, how do you manage them. By the way, I never use the term, and I have asked my students not to use the term treat pain. You manage pain. If a patient is in 9 out of 10 pain for the last 10 years, and you bring it down to 5, it's still a success. Do not promise the patient, please. That's not, that is, I think it's immoral, definitely, and absolutely unethical. And I think it's malpractice to promise something in the result. I will do the best I can. And I tell my patients, I treat, he heals. Somebody else healing. I'm not the healer. I think I just can facilitate your body healing by doing so many procedures, medications, or the combination of other ones. That's all I'm going to promise my patient. Root canal studies have been done for those of you who are endodontists. Amazing results, right? A lot of these cases start as non-odontogenic and end up as chronic pain. These are the latest studies, 2020 Journal of Endodontics, 2015 Journal of Endodontics. I mean, there is literature, scores and scores of these publications, but who wants to learn? A bunch of us within our profession, number one, want to teach misinformation, and number two, wants to learn misinformation. That's tragic, though. That's tragic. I implore you to be getting out of that nexus and look for science and evidence. Look for good mentors. Miriam Grushka is an amazing lady. Somebody, something you can call burning mouth syndrome. She is the number one author on this. And I've seen so many cases hurt unnecessarily. Cracked tooth syndrome. We are having a publication group out right now as we're talking to see if it is actually cracked tooth syndrome, or is it the fact that they fractured the tooth in the process of taking it out and then called it cracked tooth syndrome? But then again, there are some cases that will come and humble me down, right? After these 15 years of orofacial pain. And we just had a case from Dr. Deepa Jaishankar, I think, one of our fellowship students in the batch. And robust, like I'm looking at the case, I'm saying, wow, but our differential diagnosis was still there 1 year back. It proved to be, but this is an exception. And please, some wires to the head and neck on this case would not have helped anyway. She would tell you too. So new paradigm is it cracked tooth syndrome, or is it that the tooth has a non-odontogenic pain and you're looking at some crazed lines on the tooth, and with the ignorance that we have, we're connecting the two. Learn literature, please. That's my mentor on the right side, Dr. Eli Eliav. These are amazing people in pain management. Sleep bruxism is another such enigmatic area that I don't know what dental school should teach this anymore, that sleep bruxism comes from bite discrepancies. Sonal referred to this very clearly. It is nonsense, seriously. This is the sleep medicine textbook, 2,000-page book. And this is why medicine looks at us and laughs again. That grinding, the tooth contact comes so much into activation of so many other things. You can see it here. You don't have to be a neuroscientist to see this. The first thing that happens here is increased sympathetic tone. What does that have to do with bite of the teeth? Increased parasympathetic tone, increased cortex EEG, increased heart rate, increased breathing, increased electromyogram activity. That doesn't give you the power to attach this head to something else. That's what I'm saying. What I'm saying is so many other systems are involved in here, and we dentists really stupidly teach and learn that this is the main event here. It's nothing. This is not the event. The event is the rest of the events. And that has nothing to do with occlusion, nothing to do with bite, interferences, anything like that. And look at the medicine standard textbook referring to us here. Orodental splint. What does that even mean? That means we've been downgraded because the quacks amongst us have brought us a bad name for this. Let us stop it. Let us say that we are what Sonal just said. We are physicians of the stomatognathix system. Let's be proud of that fact. Not just tooth trimmers. Let's be not mechanics. Let's be physicians of the stomatognathix system and be proud of it. Let's not propagate the fact that, oh, tooth contact, okay, let me adjust those teeth. What happened to the rest of the body? And that's what this diagram shows. So please, let's stop trimming teeth for bruxism cases, for heaven's sake. I know all of you will think twice before you think, oh my God, let me think again. Please do not. Secondary bruxism, has anybody taught you this? So many syndromes, Parkinson's, Huntington's, drugs, sleep-related disorders that come with it, alcohol, nicotine, caffeine, amphetamines. I mean, really, sleep medicine has become so big, and I'm very proud to be a part of it. Drug-induced, Haldol, lithium, all serotonin inducers, all of them make you grind the teeth. So if you connect these patients' heads to some type of an instrument and think that that instrument is going to guide you, what type of education are we having? And that's my point here. Calcium channel blockers. Be robust. We have physicians from India, the guy who's looking on the right side, Dr. Anil Kumar, Janina Katzman, they are from Chile. Every country, and India has robustly been good with good brains. Let them come to science and learn the science, please. Don't let us be fooled by somebody who will sell you something. I told you in the beginning, I have nothing to sell, except, of course, I need to be paid for the fees that I will be teaching you with this because I need to sustain myself. That's it. I have no product to sell, but education that I will be just and fair with my partner, Dr. Iyer. So I have nothing to sell here. These are robust students from around the world that will help us in propagating this knowledge. Snoring. How about snoring itself is a cardiovascular risk? Nobody knew, but we have literature now, so we know this. Obstructive sleep apnea is one of my favorite topics. I'm not going to lead into a lot of this, but understand the statement here, that the screening for obstructive sleep apnea and sleep disorders, some of my students have dealt with it in a big way. One of my students in the mastership batch, her name is Dr. Nivedita. She has started a dental sleep medicine type of laboratory. So you can take yourself from being a general dentist drilling teeth to that level. And she's in Bangalore, by the way. I forget the name of the. But if she can do it that way, that she put all the knowledge that she has and become an entrepreneur, why can't you? You all can do it. The question is, do you have the mindset? My favorite book, textbook of all times, for all times in my 50 years of life, is Bhagavatam. And it says you have only one freedom, and that freedom is to change your own mind. I have only one absolute freedom, to change my mind. Nobody else's mind I can change. I can advise, but you have to change your own mind. And if she changed her mind to say, okay, I'm going to be an entrepreneur now, I have to robustly flourish in this. I love that growth. And that's what I would implore that you do by learning science. A plethora of appliances have come in for sleep medicine. We'll teach you how that is going to affect and help your practice in the long term. Obstructive sleep apnea, we know that is an inflammatory disorder. This is part of orofacial pain. It's an oxidative stress disorder. What does that mean? Does it predispose to cancer? Maybe. It's an atherosclerogenic disorder. These are shown scores and scores and scores of studies. But to have this patient in your chair and foolishly thinking that the occlusal interferences can treat all these cases with pain or untreated OSA or non-diagnosed will be foolish. And these are the bunch of students that I've had the fortune of learning. Look at the happiness in their faces when they graduate from a course like this. It's solid hours that they're proud of, solid hours. And Shankar has been amazing, and his Smile USA team. Anyone who wants to know more about this, you can contact them. Balaji is there, Arlene Fernandez, and the one who Sonal was referring to, Dr. Satish Devarajan from Chennai. They will be instrumental in giving you information on such solid evidence-based programs. And I'm telling you some of the old and new, and then I'll stop. Um, these are the old and new. Crowding of pharynx, we used to write down in our papers when we see patients. That is a sign. Linea alba bucca, not normal anymore. Scallop tongue, not normal. Attrition, is that just the bruxing habit or something else? There's so many factors. Wisdom teeth causing pain. I have heard seasoned specialists tell me, oh, that must be the impact of wisdom tooth. Show me one literature that would say that a completely impacted wisdom tooth with no cyst, well, cysts don't cause pain that much anyway, but let's assume that no cyst, and there is no communication with the oral cavity. How on earth can that cause pain? And I've heard this so many times, and then I hit my head and say, what the heck are they thinking? Where's the literature? Wisdom teeth causing pain. Wisdom teeth pushing all the anterior teeth forward. What type of nonsense? I mean, seriously, what level have we grown? Wisdom teeth don't cause any of this. The tooth cannot erupt if the gum is thick. In periodontics, we learn it. In periodontics, we learn it. And to think that four wisdom teeth will push on the mandible and the maxilla as if they're Arnold Schwarzeneggers pushing the teeth together, what level have we grown intellectually? What level have we grown scientifically? Please ask ourselves this question. And occlusion causing TMDs, I asked the orthodontist in the audience, what do you think? Do you change bites successfully, practicing for the longest time without using any of these nasty appliances on the patient's head? Please, let's go by science, literature, and evidence. I'm going to stop there. And I really love to thank, first of all, Sonal, and this organization has been phenomenal. I wish and hope everything for best for you. I hope the audience took something out, and I hope that they have at least some impetus, some incentive, some stimulation in at least looking at something that might interest their brains in the future. And I've done these seminars, quite a few in the last, let's say, 6 months plus, and previously 2.5 years. And I had the fortune of meeting several in India, several robust, beautiful clinicians they are. And I know that at least 99.999% of those students would thank me for imparting this knowledge and then let them come out with the flying colors that they have to come out. I'm just nimitta, Sanskrit, nimit. That's all I am. The duty is theirs and yours who are listening to take, research this little knowledge base that you have and flourish. Become the best butterflies in your clinical area of expertise. Add on to little flavor from Orofacial Pain. And with that, I thank you all for listening. And I take questions if you have any.
A person who knows about his privilege talks highly about not just his work, but about his students, about his specialty, and about his mentor. Talks about not minting money, but serving people. Talks about evidence and not just observations and perceptions. That was Dr. David Thomas for you guys. And I just have one word to say, sir. Thank you so much. Thank you for doing what you do, not just speaking, but mentoring. I can honestly feel what Dr. Sonal must be feeling, so blessed to be, mentee, your mentee. I loved that word, the mentee, as well as how Dr. Sonal was referring you, Dr. T. I was like, wow, that is so sweet.
Yeah, that happens to be
That's a
my
code
name.
language. That's a code
Yeah,
language.
but now everybody knows it. It was such an informative session, and I think it was like it was just a tip of orofacial pain. It was
Yes.
it's so
Yeah.
much we have. being an endo, so many cases came into my mind where I did root canal, everything was perfect, but patient was still complaining of pain. I did re-root canal, but I still don't know what happened with those patients, honestly, because
We love endodontists. The departments in both the universities that I teach, they refer those cases stat, like they don't even guesswork. They send the case and say, Dr. T or whoever my students are, have a look at this case. And if you as an endodontist doubt it, that it is a doubt is correct. It's not an odontogenic case. So that's
right.
my message to you. Take the course, join it,
Definitely, that is in fact the
fly like
first
a bird.
question. That is in fact the first question, not just from my side, but people have asked like how to know more about it. Which, like, if we want to know more about it, being
Sure.
a specialist ourselves, that because we
Yes.
are missing out on so many things. So,
Yes.
what to do? How to go about it?
Well, our next course is 150 hours. That is what Sonal is about to complete. The
Yeah.
Okay,
next batch of students is starting November 20th.
okay,
So on the 15th of November, I will be talking to the registered participants in that course. So please look up one website. I'm sorry, I don't want to switch back and forth. Smile USA.
okay. Smile
That's
US.
Dr. Yeah. It's an educational excellence program, and all the details will be there. You know my number now. If you want to just text me, that's fine too. Don't give it out to 1,000 people, please.
Sure.
I already have so much of text coming through. So, and of course, we have a Facebook group, and there are three people that you might want to look up. One is Dr. Satish Devrajan, and Sonal has his number and his address. He's a phenomenal guy. He will just calmly direct you in the right direction, or any of your audience. And then there is Balaji from Chennai, and then Arlene Fernandez from Mumbai. And 16 out of the, sorry, 20, almost 20 out of 27 people who have already registered, they attended at least one of my sessions somewhere, like probably Sonal did and other people did. Maybe a 1 day seminar, maybe a 2 hour program, or the international grand rounds that I do. So they were inspired by the knowledge that they could get. And some of them waited 2 years. And that's fine too, because the commitment of at least a year. But I intend not to teach. I intend to learn from you guys too. Like as an endodontist from you, I don't know endo the way you do. I'd be more than happy if you're thinking and telling me about an MB3 canal, but I'll teach you something about that too in pain management. But MB3 canal, you can teach me. It's a two-way bridge, right? Just like the textbook I said, Bhagavatam, it's not a monologue, it's a dialogue. And I love dialogues with my students. So
Yes,
thank you.
conversations are always good and gives us so much. I think
Exactly.
prior to this conversation, that prior to in fact listening to you, I did not know you much, so it was like I might have gone wrong somewhere in explaining about you, giving your CV and all
No,
those things.
no,
But
that's
now,
fine.
since I know you and I've heard this, I think one of the most humble person I've seen is you, because to be on the same screen with your mentor is something that we all would love to be in our life. So
Yes.
congratulations to Dr. Sonal for that, and I'm glad that you found the tip of your iceberg and your journey started. So another question that we have, sir, is
So,
are there people who are registered with like orofacial specialty? Because in case in our city we want to refer a person, a doctor, a patient to somebody, how
yes.
to refer, where to refer?
So the the 31 of them from the mastership batch, which I did not get a chance to show the picture of that, is in different cities.
Okay.
And there's fellowship students like Sonal who are already vibrantly looking at the literature and learning this, and they can handle. If they have a question, they can always come to me, and I'll be sitting with them. As a
Okay.
matter of fact, one of the I call him student, but one of the pioneers in India in prosthodontics, Dr. Rangarajan Vedantam.
I've heard. Yes.
Okay, so he's one of my students in the mastership course, and I learned from him too. In that, again, the two-way bridge. And he coined a term called BMT, basement meridian time. What the heck does that mean? Well, I sit in my basement in this house that I'm sitting right now, and 5 a.m. US Eastern Standard Time. This is all we do. We discuss cases almost every day. Either I discuss this or some publications with a couple of my students. So I've committed it that way. So any of these students, including Sonal and her batchmates that you saw in that, if any of them is in that city that where you are, Delhi, we have quite a few students anyway. From her batch itself, Delhi, we have Rita, right? And then a couple of other folks
Right,
from
right.
Delhi. Rita Sikka, she's amazing. So if you wanted to have a referral, and if they have a question, I'm always approachable for them too. And from this point on, Pallavi, I'm approachable for you too. So you can text her and take it from there. But the workup of the case, I always ask my students to do because, as you said, I'm as humble as I can. But the point is, when I see a case, I'm really, really by the book with it. And Sonal knows this already. If she has a question, she needs to present me on the form. And that is why some people would think of me as, oh my God, he's like a military man. He's like a tyranny. It's okay with me too, no problem. But yes, that's because of the protective nature that we need to employ for the patient's sake and for the clinician's sake.
Right,
So
right.
please feel free to talk to her. Yes. Thank you
Yes.
for the question.
Thank you so much, sir, for this also.
Yes.
And thank you for all the information. I think I might be disturbing you very soon because I will have
No,
so
no,
many doubts now.
no
So,
disturbance is nothing. It's just teaching I've committed in my life. And I've done 23 years of practice in the US. Um, OFP initially is not a moneymaker for me or anybody else. It's just a passion that with which you learn and you go forward. Any stage in your life, any specialty can learn this, but structured programs. That's what I advise.
yes, yes. And
Okay?
we can hear that passion in your voice. You know, when you speak, it's not just a speaker who's speaking, but a person who has given so many of years to this area, to this
Well, thank
specialty,
you.
and is still a learner. So thank you so much. I am deeply
Thank you.
honored that I got this opportunity to have a conversation with you. Thank you so
Thank
much, sir. And thank you, Dr. Sonal. And I think I'll see you soon, sometime very soon.
Yes, yes. If there are questions, you can direct it to Sonal if they have any questions.
Yes, sir.
And Sonal can channel it to either Satish or maybe Shankar or myself, and we'll take care of it.
Okay. Okay.
Pallavi, you've been. I have one question. What is the designs all around you? It's beautiful.
Okay, so my parents, we got our home renovated, so it's just wallpaper and TV panel, nothing else.
It's beautiful.
Thank you
All
so
this
much.
is wallpaper on the back
Oh,
screen.
this side is wallpaper, this one, and this
Yeah,
is the TV panel. LC, the TV is not there still.
but it looks like a design. You chose the right background, Pallavi. Great job.
Thank you so much, sir, and I'm
Okay,
super
thank
glad
you.
to hear. Thank you. Thank
Have
you
a
so
great
much.
day. Thank you
Have a
all.
great day.
Sonal,
Happy birthday.
amazing job.
Thank
You
you, sir.
too.
Thank you.
Bye.
Thank you. Thank you, Dr. Sonal.
Thank you, Dr. Pallavi. Thank you,
Thank you.
Dr. Oxon.
Yes, thank you.
So that was student mentor duo, and that was such a sweet, I would say, humble conversation, sweet conversation. How two of them, are working for this specialty, orofacial pain. I did not have much knowledge about it. There are so many cases that are coming to my mind right now that I think I need to revisit. And I'm going to revisit this whole session again. And as Sir said, Dr. Sonal is available. Her email ID will be there on the app. Do download. There's some lines that I would like to say, especially mentioned by Dr. Davis Thomas, that it's very important that we stop pulling each other down and move together, right? So, as I said, I write poetry in Hindustani language. So, here are 4 lines for this session. ये जरूरी है कि अब फिर से सीखा जाए. It's important that we start learning again. ये जरूरी है कि अब फिर से सीखा जाए. अगर कुछ नहीं आता तो ना किया जाए. एक दूसरे से आगे निकलने में उम्र गुजारी हमने. एक दूसरे से आगे निकलने में उम्र गुजारी हमने. चलो अब यूं किया जाए कि कुछ कदम साथ चला जाए. So I think let's walk together and let's not walk in front or something like that. Let's not pull each other down. Let's be a good student. And if you want to mentor, surround yourself with the people who helps you to rise in your field or who sets good goals for you. So that is very important, guys. On that note, I think today's session is done. Do remember to download the app, register yourself, because that will give you a certificate of participation, 40 CD points. You can see all these lectures on apps. You can contact the dentist directly. Their email IDs and numbers, some of them are mentioned in the app. Also, you get a chance to win Novo laser therapy machine that I mentioned, and this one, right? So the rules of this is simple, are simple. In fact, the first one, you have to download the app, register yourself. Second one, you have to actively participate in the sessions that are happening. There are still 37 sessions left. Participate, spread the word, share it with your friends, share it with your colleagues, tag them, let them know about it. Also take part in some competition, at least one, the details of which are on DRDCA app, as well as the DRDCA FB page. The last day of submitting your entries is, I think, 10th November. And 5 days, yeah, 5 days left. And that's it. Download the app as fast as you can. The next session that we have, the next session is my favorite one when I read about it, because it's an endo special. So being an endodontist, I am looking forward to it. It's on Saturday. Morning session is with Dr. Dharam Hinduja and Dr. Niharika. Evening session, we have 3 speakers with us, Dr. Ahmed Madrati, Dr. Ashraf Rifai, and Dr. Prashant Bhasin. So very renowned speakers, and it's an endo day, yay! Morning, 11 o'clock, I'll see you Saturday on your screens. Till then, take care. Enjoy yourself. Bye-bye.